Welcome back to this week's episode of Hormones, Metabolism, and You. I'm your host, Dr. Cassie Smith. I'm a functional endocrinologist with a practice based out of Oklahoma City. Today, I had the privilege of interviewing Dr. Terri DeNeui. We had a conversation about women's health. We talked in particular about how hormones change throughout a woman's life. Most notably, how in our 30s we start to lose testosterone and in our 40s progesterone. We talked about what symptoms this causes, what women will start to experience, what lab tests they can look for, and then ways we can treat this. We then talked about after our 40s when we actually need hormone replacement therapy in the form of estrogen therapy as well, when it is appropriate to add estrogen therapy, how you do that, and how long you can take estrogen. We also discussed the hypothetical or mythical conversation around does hormones cause cancer. I found this conversation to be very insightful, very educational. So if you are a woman who, is in their 30s, 40s, or 50s, this will be enlightening for you, I believe. So I'm so excited for you to hear this conversation. Dr. Terri DeNeui is a board certified nurse practitioner, nationally renowned speaker, author, and entrepreneur. She holds advanced certifications in hormone replacement therapy, preventative wellness medicine, and functional medicine. Dr. DeNeui earned her bachelor's degree in nursing from Texas Women's University and achieved both her master's and doctorate degrees in nursing from the University of Texas at Arlington. She's the founder of Avexius Health Solutions and creator of the Avexipel method. She leads the Avexius Medical Advisory Board, hand-selecting leading experts from around the globe to support the education and knowledge resources that provide the opportunity to experience a whole new way to practice medicine that's truly transformational for patients and practitioners. She founded Hormonal Health and Wellness in Southlake, Texas, now known as Avexius Medical Center, in 2008 as the first step in her new pursuit. Prior to that, she was a hospitalist in emergency medicine. In her practice, Dr. DeNeui strives to help men and women find optimal health. Her success and the positive outcomes that her patients enjoy can be attributed to her thirst for knowledge. She says, "I will never stop asking questions. I will never stop seeking answers. If a patient is not achieving optimal results, we must ask more questions and uncover the answers. Sometimes answers we didn't know were there when we first asked the question. Medicine and science are ever evolving. We can never stop asking questions or seeking answers." This is why I love her, because you guys who listen to me know that I feel the same way. I always want to know why. That thirst of knowledge led Dr. DeNeui to discover pellet therapy and the benefits of testosterone in women. 15 years ago, she traveled to Arizona to train with Gino Tortora, one of the pioneers in hormone pellet therapy. Her experience there led her to introduce pellet therapy into her practice and evolve her treatment methods. In a few short years, her methodology became renowned, evolving into a brand known today as the Avexipel method. To date, thousands of practitioners have been trained and certified in the Avexipel method, and tens of thousands of patients are living happier, healthier, and better lives because of Avexipel. So I hope that you enjoy our conversation today around hormone health. Welcome back to this week's episode of Hormones, Metabolism, and You. I'm your host, Dr. Cassie Smith. I'm a functional medicine endocrinologist. Today, I am interviewing Terri DeNeui. She is a nurse practitioner and she actually has her doctorate. She does all these amazing things with hormones. And so she works with a company called Avexius. I'm going to let her tell you about that. But I brought her on today because I wanted her to tell you guys, just like I do, more about hormones. So we're going to talk about our life as we transition as a woman through our 30s, 40s, 50s, and 60s, how our hormones change, what we can look for. And then we're going to ask her the questions you guys have, like, does hormones cause cancer? Should I stop my hormones at any point? And so she is just a wealth of knowledge. And she's also written this amazing book, which you guys know that I've talked about and I love, Hormone Havoc. So I'm going to let her tell you guys about that as well. So thanks for coming on.
So appreciated. It's my passion to educate and get the right information out there as you are. So I really, it's an honor for me to be here. Thanks for having me.
Yeah. So take a minute and just kind of tell everyone, I guess, your journey, like where you started, what you do now, so everyone kind of knows, that you know what you're talking about. Let's
Yeah.
give you some credibility.
Okay. So my background as a nurse practitioner is in emergency medicine, and I worked for a big hospitalist group in the Dallas-Fort Worth Metroplex for many years. And before that, I was in labor and delivery and women's health, and I kind of transitioned out of that. Didn't think I was going to be back in the women's hormone world, but here I am. But one of the things that really bothered me about what I did, especially with the hospitalist group, emergency medicine's fun. You're stabilizing people and getting them, moving on down the road for the next thing. But even in the emergency room, and especially as a hospitalist, what I recognized, pretty quickly is that pretty much 90% of what we were treating was some sort of exacerbation or complication of a chronic disease that was preventable. And I really started asking this question, why aren't we doing more for disease prevention? And so I just started on this quest of educating myself really and going to other conferences outside our traditional medical conferences and just learning some other things. I was exposed to this concept of functional medicine, about 16 years ago. And I really thought, okay, there's something here. And there was a specific story, actually. I was sitting listening to a doctor speak, and I can't remember her name, but she had written a book called Awakening Athena. And she was telling a story about a woman, and she was sharing this profound life change, not only in how this woman felt and showed up in life, but just some disease reversal in this woman, hypertension and some metabolic issues, things like that. And I just had this aha moment that this was a key missing piece of our education. So I kind of started going down that track. I eventually partnered up with another clinician and opened a private practice, and she did weight loss and wasn't really interested in hormones, and so asked me if I wanted to take on the hormone piece of her weight loss clinic, and it just kind of went from there. And I ended up meeting. Actually, what really happened is I was losing some patients to a local doctor who was doing testosterone in their patients, and nobody had ever taught me about testosterone in all my training in advanced hormone education at different conferences. Nobody was talking about testosterone in women 15, 16 years ago. And so when I met with him, there were so many unanswered questions with my patients that were like, this is the missing piece. So then I delved into that education and brought testosterone therapy along with the other hormone optimizations back to my clinic, and it exploded. And it's been a journey of learning for my patients, continuing to research. I've just saw a lot of things happening with my patients with being able to get off antidepressants and get off sleeping pills and get off anxiety medicines, and just so many medications that, especially for women, just kind of make worse a lot of the symptoms that we're trying to overcome, like libido and energy and weight and things like that. So, and then I started realizing that I could do a lot better and impact a lot more people if we educated more clinicians. And my husband, now, we weren't married at the time, started another company with another doctor and began training doctors all over the country in hormone therapy, specifically hormone pellet therapy. And it just really has kind of taken off. And when I paused from that for a while to work on my doctorate, and then, for the last 5 years, people are like, you need to write a book, you need to write a book. And so really the book is a culmination of years of research and teaching and really dispelling a lot of myths. There's still so many myths and misconceptions and fears about hormones, which I think we're probably going to talk a little bit about today. So it's a little bit long explanation of the journey, but that's kind of how I got from emergency hospital medicine, acute care to where I am now.
Yeah, I love that. I think most people in our position have this story, and it usually, comes from a question of why and why are we not trying to prevent things. And then it just kind of evolves into this wonderful, I call it divine timing, just like everything kind of falls into place, right? And you have this mission, right? And then once you have this mission and this desire for something that, is like burning inside you, that's what I tell my staff all the time. Like we're like this speck in the universe, right? But if you can educate and empower people to learn things that help them, make their health a priority and make them feel better, then they can do what they're supposed to do on this earth. And then it becomes very powerful.
Absolutely.
So,
And people are hungry for that right now. They're hungry for the truth. They're hungry for, you know, uh, just answers, because I think the last 4 or 5 years have really woken us up to, I think we could do better. So
I know we can do better. So yeah, I would
I
agree.
know we can do better. Yeah.
So I kind of want to start with, so this is going to be more tailored to women, although I know you do hormone replacement in men and I do as well, but I think it's really important for women to empower them, especially even in their 20s and 30s. And so I kind of want you to describe to women who are listening to this. Let's talk about, we start having menstrual cycles in our teens. Some people are starting even earlier than that now, but we start having menstrual cycles in our teens, and hopefully we're somebody who has them, maybe they're regular, we're having normal menstrual cycles into our 20s, maybe beginning into our 30s. Although unfortunately a lot of women end up on birth control in their teens, and then that causes a whole bunch of issues because they have painful periods, right? And instead of using our brain and saying, why are we having painful periods? Let's figure this out. We just give people medicine to shut them up. But let's say that we're one of the few who have started our menstrual cycle in our teens and have progressed into our 20s, and now we're in our 30s. And maybe we were even on birth control and now we're off. And maybe we're even having normal periods. What are some of the things you're going to start seeing in your 30s as a woman as your hormones change? Like, we're not obviously going to have hot flashes usually, but what I see in my patients, I'm curious with you, is that in your 30s, you can start to lose not only progesterone, but testosterone. That's earlier than we used to. And so, what are kind of some of the things that you'll see in your 30s as a woman as your hormones change, symptom wise and just feeling wise?
Yeah, so as our 20s are supposed to be our main reproductive years, and I think that's part of it. A lot of women are waiting later to reproduce, but especially if a woman has already had babies in their 20s, the combination of that and then turning 30 just really decreases our testosterone production. And the first thing that a lot of women don't even realize, that we make testosterone. It's been purported as a male hormone, and women actually make testosterone. Our ovaries, this, make testosterone. It's a powerful hormone. It does peak in our 20s, in our reproductive years, but it's not just about reproduction. It's so much about brain health, and so many women, what they'll start feeling is a kind of a depressed mood, maybe more anxiety as their testosterone lowers and their estrogen is still clocking along really good. They get a little anxiety, definitely mood swings, and just energy, overall fatigue. They might start seeing body composition changes, like it's harder to stay fit sometimes as their testosterone lowers. But the biggest symptom, I would say, women that I've seen women present with in their 30s is depression, anxiety, irritability, mood swings, not sleeping well, and fatigue. Those are kind of the big ones. And then every decade, those get worse as our levels decline. But we do start losing testosterone in our 30s. And you mentioned birth control pills, and birth control pills actually also lower testosterone in two ways. It shuts down ovarian production of testosterone, but it also raises a protein that binds up free testosterone. So it's kind of a double whammy. Women that are on oral birth control pills have even lower testosterone than they would have off of it. So it causes a lot of those symptoms. And then we'd be remiss not to talk about, lifestyle and the gut and diet, because that all plays a role in hormones and hormone metabolism and how all that works. So
Yeah, and that's one of the things I really like about your book is that you throw all the hormones in there. So not just do you educate people about estrogen and testosterone and progesterone, but you talk about thyroid hormone and you talk about melatonin and you talk about growth hormone and all these hormones that are really important to your gut. And that's the thing I think that we have a problem with in this country, is that when your gut's not healthy, it's impossible for your hormones to be healthy. Like they and so we have a lot of people who have terrible guts, whether it be from poor lifestyle choices like food, stress, but also sleep. Some of it is just, the vaccines that we had, or maybe how you were born, all the antibiotics your doctor gives you. I mean, there's so many things that play a role. to it. You know, their doctor gives you birth control, your doctor gives you an antibiotic when you have a viral infection, just all these crazy things that then prevent your stomach from working the way your GI tract is supposed to. And then that feeds into disrupting your hormone balance. And so in addition to that, you're stressed out and you're, you know, trying to do a million things and you're not sleeping and we're not eating well. And just, it's no wonder that nobody's hormones work.
Well, younger and younger, exactly. And then, you know, add in the layer of technology and never letting your brain rest. I mean, it's multifactorial, and we're seeing more hormone disruption in younger people now than ever before in our history. And it can all be pulled back to the majority of it to the gut and stress for sure.
Yeah, I would agree. And so I agree with that. In 30s, I see women who the anxiety, depression, the brain fog, the fatigue, the my body's changing. And then I have a litany of women who are in their 30s who don't like to have sex with their husband. And that is alarming. Alarming.
Yeah, I don't even know.
Yeah.
I don't even know why I didn't say low libido, because that is the big one. And that's kind of, I mean, I always kind of think that's the obvious one. But yeah, that, you know, the relationship piece of losing testosterone is the one that breaks my heart the most, because yes, women lose interest in sex, and that's a deal breaker for relationships. I mean, you know, I tell women all the time, guys can handle you being moody and cranky and irritable, but all those things and not having sex, it's kind of like, it's a double whammy. So it's frustrating, and men take it personally, and you know, it's a whole dynamic that has to be talked about for sure.
And so that's what I would see as well. And then as they transition into their 40s, you know, right around 40, I feel like it starts to get really bad because I feel like not only are you losing more testosterone, but then they start to lose progesterone too, right? Is that what you see? And so what do you see in your 40s typically?
Yeah, so it's kind of strange. It's almost like 40 and a day, all of a sudden things change. And progesterone is a big one. And what happens is progesterone is somewhat of a calming hormone. So when everything's in perfect harmony, you've got estrogen, testosterone, progesterone is like, if you're to your point early, if you're not on exogenous hormones, if you eat well, if you've got a healthy gut, everything's kind of in harmony, right? And then you start to lose testosterone in your 30s, and then things kind of get out of whack. And then you start to lose progesterone in your 40s. And that's when the anxiety ramps up a lot more, especially right before their cycle. Pretty much all those symptoms of moods and anxiety really just get worse when progesterone starts to decline. And the telltale sign for a lot of 40-year-old women is their menstrual cycles become very heavy, very cloddy. They'll say, you know, I can't, you know, get out of the house without a, you know, super protection for 30 minutes. You know, it's just so heavy for the first few days. And that's the telltale sign your progesterone's low. And a lot of women at that point might visit their OB-GYN and get put on a birth control pill, which is the worst thing to do in your 40s, or be put on an IUD, or get an ablation, which is probably it's the least invasive as far as like hormone, you know, putting yourself on hormones. But it's not fixing the root cause. And you said something earlier that's so important. You have to get to the root of it and quit band-aiding. And there's one thing I really tried to educate in the book, and even when we're training other clinicians and doctors and nurse practitioners, is we've got to kind of shift out of this allopathic mindset of giving a prescription to band-aid a symptom, and really peeling back and looking at the root cause. And I'm not anti-prescriptions, but the majority of prescriptions that we prescribe in this country were never meant to be lifelong solutions. They were meant to be a stopgap solution to simmer the fire while you figure out what's causing the fire in the first place. But unfortunately, as a society, we've kind of become dependent on these things rather than looking at the root cause. So, but that's the biggest things. It exacerbates the moods. The anxiety ramps up, and the menstrual cycles get really heavy and um, hard to deal with.
And sleep. I find that when your progesterone goes down, your sleep goes out the window. And so, yes, I feel I agree. Like it's like something with 40 and all of a sudden women are like, and then, the unfortunate thing is they go to their OBGYN and they tell their OBGYN, and to your point, they say, well, you need an SSRI and or birth control. And like, no, you don't, because that makes everything worse. What you need is to figure out the root cause. And also to your point, I feel like the problem with Americans in general, we are very like, we want a quick fix. We want to know what's wrong, and then we want it to be fixed yesterday. And it's like, well, it took 40 years for you to develop this issue. It's not going to fix itself overnight. But that's where I think the line of medication people become very long, and the line of lifestyle and health choice of people become very short, because we are all worried about tomorrow instead of 10, 20, 30 years from now. And we have to change that mindset in this country. And so I see that as well, in your 40s, your testosterone's still going down. And so that's when I feel like too, in your 40s, it just becomes a really big mess. Like their insulin starts to go up, they start gaining weight. They're also losing muscle because they don't have testosterone. So then they're gaining weight even faster now that we don't have the testosterone. You become a big metabolic mess, unfortunately. And you need,
Absolutely. And the libido gets worse. You're not sleeping. You're crankier. You're moody. Like it makes everything worse. And progesterone is, like I said, a calming hormone, and it's just powerful, powerful for sleep. But the other thing you said something really important there with all those medications and those solutions that we're given, making things worse. And that's kind of the thing that I see the most. And our 40s is typically when, or after that second baby, whichever comes first, is when so many women get placed on these SSRIs, antidepressants, like Prozac and Zoloft and those others. And what happens is it doesn't fix the problem. It makes them emotionally labile. So they're not happy, they're not sad, they just don't care. And the other thing that happens, because there's a correlation between low testosterone and cortisol levels start to go up, and that lays down belly fat and causes more insulin resistance. And then you get on this hamster wheel of, well, now you need a prescription for this and a prescription for that. And as you know, just really starting to optimize those hormones and that lifestyle makes such a huge difference. And this concept, you said something so important about wanting a quick fix now and an answer now, and not looking at the long-term solution. And I heard somebody say one time, and it's kind of true, people want change, but they don't want to change. It's so hard it's a lot easier to take a pill to fix all your problems, right? But the trade-off long term is not the best solution, as you know. It's a terrible solution, actually.
yeah, I ask my patients this a lot. Hippocrates said, if somebody asks you if you can fix them and if they don't want to be ill anymore, you have to ask that person, are they willing to give up what made them ill? And a lot of people are not willing to give up their Diet Coke and their, bottle of wine every night. So it is a give and take, but also it's our job as a provider to meet them where they are and to start giving them educational information as to what are little things that you can do to start moving in the right direction. And the other thing, the women who are listening to this in their 40s, I mean, the thing that infuriates me is by the time they get to somebody like me or you, they, to your point, they don't feel well, they're anxious, they're moody, they're tired, they don't, they're like, I don't know why I don't want to have sex with my husband. They go to a doctor who they, trust and confide in, and the doctor says, you're fine. You're fine. Here's the medicine. Yeah. You're fine. This is normal.
Your
and they go
labs
to
are
two of
normal.
them or three of them, and they all say that. So then they are thinking by the time they get to you or me that they are broken. Something is wrong with them. And that's what really makes me upset. And that's what we have to change, right?
Yeah.
Like it's not you.
Yeah, that's a story after story. And you know this because you've seen this in your practice, but it's a great reminder of why we do what we do, because we get busy and we get in, our busyness every day. But when you sit down with that person who's been to 2, 3, 4, 5 other clinicians and have been told you're normal, your labs are normal, and then when we tell them, no, there's some things here that are explaining why you feel the way you do, you kind of see the hope light up their face, like, oh my gosh, there's an answer. I thought I was crazy. And my relationship, my husband's, we're fighting all the time, and I've had patients on the brink of divorce. I had one couple that literally had filed for divorce and was separated, and they both had heard about this hormone therapy that you and I do and came in together and are married to this day. So the relationship piece, is so key. Feeling good is so important, but the ripple effect of that relationship piece on families and on generations is really what drives a lot of what drives me, actually.
Yeah. No, I agree. I tell people all the time. I was on vacation last week and somebody said, "What do you do for a living?" And I said, "Well, I'm a chief validator." And they're like, "What do you mean?" I'm like, "I just validate people's feelings." Like that's what I do. I validate the fact that you
That's
don't
right.
feel well. I show you that you don't, and then I help you feel better. I mean, and it's a really good
That's
feeling,
right.
right? Like
It's
people
good.
just want to be validated and then they want to you have to start with that. Like you have to know that you have some sort of issue before you can climb out of that hole. So if you've gone to 3 or 4 providers and they give you no hope, then you're probably not going to be motivated to do anything differently, unfortunately. So then also I want to ask you because I hear this all the time. So I heard this from a 39-year-old this week who's just, she's a very high achieving person, very much like myself and you. She owns a business, she's busy, and she said to me, "Well, Cassie, I don't need to start hormones now, do I? Because although it looks like I'm in menopause, like I'm only 39. And so my doctors are saying I need to wait till I'm 50." And I'm like, "Well, no, that's not your biological clock, sister." Like, right? So talk to me about that if you are 35 or you're 39 or you're 42. If your progesterone is low, we can even start with that. Is there a time you need to wait before you start it? Or estrogen, like, because that is a huge misconception, in my opinion.
Yeah, the time to start hormones is when your hormones are depleted. It doesn't matter the age. And some women, this happens earlier. Some women, it happens later. There's a genetic component to that, as you know. There's how many babies have I had component, because that plays a role in how quickly we deplete things like testosterone. But there's some, the progression I see most often is, women coming in their 30s, we replace their testosterone, that they ride that out, and then they hit their 40s, and then you have to layer in progesterone, maybe thyroid, maybe some other things, it depends, and then in their 50s typically. But not all women follow that nice bell curve, right? As you said, I mean, I had a patient just the other day that went through early menopause at 39, and she's now 52, and she hasn't been on hormones for 13 years. And she just, you can see it on her face and her skin and her countenance, and just the gosh, the loss of hope that this is just my life, this is just my life, and this is what I have to deal with. And it's not that way. So there is no age factor of how long you wait and how long you should stay on them. It's so individualized. There's a bell curve average where women fall into, but there's always outliers.
And that bell curve average, I think, is shifting to younger from what I've seen in the last 7 years. And I also think it's important to point out, like to her in particular, she feels like something like it's almost like her fault, right? Like, well, I shouldn't need this, I shouldn't. And I'm like, no, I mean, no, that's just where you're at right now. Now, if you fix your stress and you fix your gut and you fix your sleep and all these things, could it get better? Maybe. But I said to her, are you going to stop working 90 hours a week? Are you going to sleep 8 hours a night? Is your business just going to all of a sudden evaporate? No. Okay, well, then we need some hormones, right? Like, and I think that that's the other thing too, is like, you can't take it personally, right? You can't, I mean, there are things you could probably do, everyone, myself included. There's something I could do to make myself better, but we're kind of doing the best we can as humans in the life that we're in right now, and seasons change in life. And so I hate it when people feel like, oh, I can't take a hormone because I'm not at the age that my doctor says or the world says or society says. Because I tell my patients this all the time, you are an N of one. It doesn't matter what society says, what medicine says, what you are you. And so we are here to make you better, right? And so whenever you need the hormones, you need to take the hormones, right?
That's right. The problem is there's not a lot of clinicians that understand how to diagnose and optimize hormones, because we're trained, right? I mean, you can speak to this, but most of us are, well, we are all trained nothing on hormones until now. Endocrinology world may be different. I'm just talking about in the general education world of clinical education. But we're basically trained that at some point in a woman's life she's going to start having hot flashes, and at that point you can give her some form of estrogen, and it's usually an oral estrogen or a patch and some synthetic progestin, and then when all those go away she can go off those medications. That's pretty much what we're taught, and it's so backwards. There's so much missing to that conversation.
Unfortunately, I will tell you, as a board trained endocrinologist at a very good university, That's what I was taught, nothing more. That women need estrogen for their bones. They teach us a little bit about their bones. They don't teach you anything about their brain, their heart, but they say, yes, women will develop hot flashes. Only at that point should you put them on estrogen. It should be a pill or a patch, which, by the way, the pill does the same thing birth control does. It increases that protein you were talking about, sex hormone binding, which then tanks your testosterone. At that point, you put them on it for the lowest dose for the shortest amount of time as possible. And when the symptoms go away, you take it off. They never talk about progesterone in sleep, never talk about it perimenopausally. They never even talk about giving progesterone when women are having problems conceiving, which is a whole other conversation. They don't really talk, they didn't teach me anything about testosterone in women, and they teach you minimal about testosterone in men. And that is a typical American endocrinology fellowship in the United States. So when I got out and I started learning other things, I was like, dear God, it's so unfortunate, right?
Yeah. It does need to change at that level, and at the education level, because the one specialty area that, most of us would rely on to have the latest, greatest, most accurate knowledge would be endocrinology, but what you just described is the allopathic model, right? I mean, it's just at some point they're going to get a symptom and you're going to band-aid that symptom with this drug, and not really, I mean, all the data about the lack of estrogen and stroke risk and and dementia risk and cardiovascular disease risk, like how is that missing from the educational platform is beyond me, because it's not because the studies aren't there, but I guess it's whoever's writing the textbooks. I don't know.
Yes, and who's funding those textbooks. And for anyone who's listening, I have personally asked the University of Oklahoma's endocrinology fellowship to allow their fellows to come rotate with me. It is 1 mile away. I would be happy to have them. I would be happy to have any endocrinology fellow come to our clinic and rotate with me if for a credit to learn these things, because it is, when you get out there in the real world, it is just mind blowing. And to your point, I mean, all doctors need this. I mean, residency programs as well. If there's a residency program listening that wants to send some residents, like, I'm happy to help train those people, because it is just, when you get into the real world, it is so impactful and so powerful. And that's why I do what I do, because as a, endocrinologist, I was just writing drugs and writing drugs and writing drugs. And I looked up 3 years later and I was like, none of my patients are getting better. And I spent 14 years going to school, and this is the most disheartening thing I have ever done. And so that's what brought me into, the world of hormones, and it's so different. So then that transitions me to the next question, which you brought up. So the next thing that women will say to me is, okay, well, I guess I need some hormones. I guess I believe you. Like, because we do talk about, it's good for your bones. It's good for your brain. It's good for your heart. It's good for your skin. It's good for your sex drive. It's good for everything, your mood. And so then they say, okay, well, Dr. Cassie, but I had somebody tell me this yesterday. My OBGYN and my primary care doctor told me that hormones cause cancer, that they are 100% sure they cause cancer. Let's talk about that. My first response to that, just so you know, was you need a new OBGYN. And
we have OB-GYNs that we work with and teach with. And so there's a lot of educated people that have gotten outside all of that old bad teaching. But the first thing I want to say is, I read a great study that said it takes 8 to 13 years for the medical community to change a practice after the evidence has been presented that current practice is no longer valid. So there's the thing about cancer. So as I'm saying this for your listeners because I know you know all this, but the Women's Health Initiative trial is what really messed up hormones for women. And it was the largest research trial to date that focused on women's health. And the reason they did the trial is that they were seeing that the oral synthetic Premarin estrogen was showing that women that were on that were having decreased cardiovascular disease. So the primary reason they did the trials, they wanted to prove that estrogen hormone therapy prevented or slowed down cardiovascular disease. And then they also wanted to check safety as it related to invasive breast cancer. So that was the whole reason for the trial. So they had the two arms of the trial, that the synthetic estrogen only, Premarin, and the synthetic estrogen plus progestin, which is not the same as progesterone, Prem Pro arm of the trial. And they stopped the trial early because in the Prem Pro arm, there was overwhelming evidence that it increased the risk of Alzheimer's disease, cardiovascular disease, and and invasive breast cancer. So they stopped the trial just in the Prem-Pro arm. However, the media reported and really applied this concept of a single class effect. In other words, we threw all hormones out because we've kind of threw the baby out with the bathwater because of this one bad progestin hormone. And so what the media purported is that hormones are bad, they're going to kill you, they're going to cause cancer, they're going to cause heart attacks, they're going to cause strokes. And that kind of became the religion, really, starting in 2004 all the way up to even now. I have published a paper on the WHI. I mean, it's crazy how we haven't unraveled from that. However, this is, and it was on Time Magazine, the front of Time Magazine. No, hormones aren't as safe as we once thought. What's a woman to do? And created all this fear and everything. But in 2020, and all of you listening, you can find this article online and take it to your primary care provider and your OB-GYN. JAMA, the Journal of American Medical Association, published a study, same authors as the Women's Health Initiative trial, and they had looked at all the data over the past 20 years in the WHI and actually concluded that the one and only drug that has been shown in a double-blind, placebo-controlled, which is the best of the best of the best, trial to prevent breast cancer and decrease death from breast cancer was estrogen. The worst drug probably is Premarin, but it's really not the worst drug, right? Because this study actually showed that it protected the breast, and it protected women who might have gotten breast cancer from dying from breast cancer. So that was released in 2020. So we still have another decade before I think the conversation starts changing. But it's podcasts like this, and it's educating consumers and educating clinicians that will get the word out, because clearly most doctors have not seen that study because they're giving bad advice, just like your patient had yesterday. And I see it every day in my clinical practice too. So we can talk a little bit more about breast cancer if you want to go there, but absolutely unequivocally, the only hormone drug that has shown in any study to increase breast cancer risk is progestin, not the same as progesterone. So I get excited talking
No,
about
me
this,
too.
obviously.
And
My
for all my
energy went up.
patients listening to this, before you freak out, micronized progesterone, which I give you, is not progestin. So,
That's why I keep
yeah,
saying
yeah.
progestin.
So, and we talk about that. Micronized progesterone is not progestin. And yeah, and so to your point, I mean, I say this all the time, estrogen does not cause cancer, period. Like, full stop, end of discussion.
Full stop.
Estrogen does increase your brain health, increase blood flow to your heart, prevent you from getting heart disease. It helps your bones. It helps your skin. It helps lubricate everything. It helps pull your skin up.
Yep.
You know, it helps with elasticity. It helps with vaginal lubrication. It helps decrease your risk of UTIs. I mean, all of these things, period.
The list goes on and on.
Yeah. And so now, to be fair, can your body make bad estrogen? Yes. And that's kind of outside of this conversation. And I have this conversation with my patients. The problem is that our body makes more than one type of estrogen. And so there are pathways where your estrogen can be metabolized into bad estrogen. And that's why some people end up with breast cancer. But that's not what we're giving you when we replace your estrogen. And to your point, there have been studies, I tell people this all the time, there have been studies that show you are better off after breast cancer on estrogen. You will live longer, your mortality rate will decrease. So you have a breast cancer, even if it's ER/PR positive, you have your treatment for your breast cancer, you go back on estrogen, those people live longer, are happier, have, lower mortality, lower morbidity, and way better quality of life. And I tell people this all the time. And I have so many women who come to me now in Oklahoma City, and I'm happy to take care of them, who have breast cancer, who have seen doctors, who are miserable. They can't think. They tell me, I have women who tell me, I would rather die than live like this. And they've lived like this for 5 years and no one will give them estrogen. And I'm like, that is not, as a provider, that is not your decision to make. Like, no, first you're supposed to do no harm, but if you're not doing any harm, for God's sakes, make somebody better. Like, you don't get to be the dictator of their health care. So it's very frustrating. So to your point, then hopefully in 2030, we'll be having a different conversation.
Well, and the other side of that you've said so many great things, but The other piece of that study is that study actually showed estrogen to be preventative of breast cancer. So women that were on estrogen therapy early and stayed on it had lower rates of breast cancer than women that didn't go on breast cancer or went off on estrogen or went off of their estrogen. So that's a really important thing to understand, this whole concept of estrogen. And you said, I know we're not going to talk about it in this, but I just want to plant the seed and nurture, water this a little bit because you dropped it. There are ways that our body metabolizes hormones that can increase the risk of, cancers, breast cancer, or hormone type cancers. But that has everything to do with our gut health, our stress. I mean, all of the things that we talked about. So there's things we can do to mitigate even that from happening, that I know is outside the realm of this conversation. But I don't want people to just think, oh, well, there's a fear factor then, oh, well, estrogen, but what if I'm one of those people that my body metabolizes it this way? And, it's not that. There's ways, and you know this, and this is the functional medicine piece of what you do. You don't ever, I'm sure, I know you don't just replace hormones in somebody without having a conversation about how that's metabolizing and give them help with metabolizing it in a healthy way.
And not only do I do that, Dr. Terry, but we also check in anyone who is concerned. I check estrogen levels. And I don't know why oncologists don't do this. I don't know why primary care doctors don't do this. Like, I tell women all the time, if you're highly concerned, let's just see what your baseline estrogen level is. And if it's high, I'm like, okay, you're a bad metabolizer. We need to figure out why. Let's clean out your gut. Let's fix your sleep. Let's look at your cortisol. And this is why it's really important to go to someone who understands hormones, right? Because I don't care if you're at the highest risk. Myself personally, I'll just tell you, I have a huge family history of breast cancer, ginormous. You will pry estrogen out of my dead hands because I have done a Dutch test. I know how I metabolize my hormones and I check it on myself. And when my estrone, if it starts to go up, then I'm like, okay, I have a conversation with myself. What am I doing? Do I need to change some things? I will take estrogen until the day I die because and so the frustrating thing is, like, even if you are at higher risk or even if you're making estrone, which is the bad estrogen, there are ways to prevent this, right? There's so many ways we can help you metabolize your estrogen better. So that's the frustrating thing too, is like, it shouldn't, these are conversations that we have to get more comfortable having with people. And as a patient, if you have this conversation with a provider and they have no idea, if you ask a provider to check your estrone level and they look at you like you're crazy, find a different provider. I don't know what else to say. Like,
Yeah, that's right. I love that you said that, is estrogen is so inflammatory, and it's the cause of so much, but that is such an important piece of the equation. And also, I share with my patients often, I kind of do a reverse consent, and I'll say, okay, here's the things that you're at high risk for if you don't replace your estrogen: cardiovascular disease, Alzheimer's disease, exponentially colon cancer, obviously osteoporosis, that's kind of a no-brainer. Strokes, there's a role for estrogen in preventing stroke or preventing damage post-stroke. So there's just so much evidence, and I'll be 58 this year, and to your point, I will die with an estrogen pellet in in my butt. There is no age that I will stop doing it, because the vitality and the disease prevention is it's indisputable, really.
yeah, it is. And so just the education piece is so important. Kind of the last thing I wanted to transition and ask you before we wrap up is, so people say to me, okay, Dr. Cassie, let's do estrogen. And so we get them on estrogen and they're doing great. And, we monitor them. And then around 60, they come in and say, well, my doctor, I saw my doctor. This is my favorite part. I saw my primary care doctor and they said, since I've been seeing you, I've been doing fabulous. My blood pressure's down. I've lost weight. My cholesterol's down. I look fabulous. My joints don't hurt. That's the other one, joint. Like, my joints don't hurt. I can exercise. But
Yeah,
they
that's
said,
joint pain.
I've been on it for 7 or 8 years now and I'm 60, so I should probably get off of it. I'm like, okay, let's have this conversation. So at what age should we get off of our hormones, Dr. Terry?
Yeah,
Never. As long as
never. As long as you're breathing. Yeah. So the bad information about lowest dose for shortest amount of time, which by the way went away in 2017. Most doctors just don't know that. Came from, again, the Women's Health Initiative trial, and they noticed that there was a 10-year window of opportunity that women should, get hormones and stay on them only within 10 years of menopause. But that was found to be only true in the progestin arm. If everybody can just wrap their mind around, the progestin arm of the trial was the bad part. Even the synthetic estrogen arm, everything was good. There was a slight increased risk of blood clots and strokes because of the oral modality, but everything else, there was just no issues with it. And so the North American Menopause Society actually put out a new guideline in 2017 that said, based on all the data they've been looking at since WHI, they realized that the WHI wasn't representative of the average woman that transitions through menopause and that will go to a doctor's office to get treatment for. And they based that recommendation on the population in the WHI were over 30% of them were obese. Somewhere close to 70% had some sort of metabolic comorbidity, and they were over 70. Many of them were past an age that you would typically start hormones on. So it wasn't really a representation of the average population that women seek help for menopausal symptoms. And what they realized is there were more risks of death and dying in the group of women that went off their hormones than the women that stayed on their hormones. And so what they changed in their recommendation is it's no longer a lowest dose for shortest amount of time, but they actually shifted and said it really needs to be a conversation between an educated clinician and the patient, and a decision made based on that patient's unique risk profile, comorbidities, what other diseases do they have, what are they trying to accomplish, all of those factors, and then make a decision with that patient as the best route forward. Which I always say, thank you, NAMS, for giving us permission to do what we're trying to do anyway. But that's where that guideline came from. It's been gone since 2017. So if any of your listeners hear that, they can educate their doctors that that's no longer the case.
Yeah. And the key there is an educated provider. And to your point, I just want to say this too. So in prep for this podcast, I reviewed some stuff yesterday. In my personal practice, I have about currently 2,000 patients on hormone replacement therapy. And 95% of those are women. So in the last 1 year, I have had 7 patients diagnosed with breast cancer, but 3 of them were not on hormones. So 4 were. Of the 4 that were on hormones, 2 of them had a biopsy of a DCIS, which is not even really a breast cancer, but we won't go there. When they got a lumpectomy, they were like, oh, wait, that's actually not even a cancer. No shit. So 2 people have had breast cancer on hormones, 3 not, but to be fair, I have way more people on hormones than not on hormones. So 2 people in the last year. If you look at the number of women who should have breast cancer in a year, I mean, it's almost 1 in 4, right? Like 25% of people get breast cancer. And so what I want to do, and maybe we could do this together, I want to pull a bunch of people who do hormones correctly and pull the data of how many people get breast cancer. And by the way, both of those women are back on hormones post. They were treated appropriately. They both came to me and said, I cannot live without my hormones. 100%, I'll give them back to you. We're checking estrogens. We did Dutch tests. Like, they're doing great. But I would like to pull data with people who do this and see how many patients that actually take hormones get breast cancer versus the general population. Because I feel like I'm very lucky that I don't have to deal with a ton of breast cancer when I get people on the right hormones to begin with as well.
Same. I mean, I can probably count on 2 hands in 16 years that we've been doing this therapy in our practice, and the number of breast cancers that we've diagnosed, and the majority of them actually, we diagnosed them early on in their treatment regime, simply because we were, doing the diagnostics, and to your point, getting all the right tests and looking at things, and all of them resolved because they were caught early. So yeah, I would love to officially collect that data. I've unofficially collected that data in my practice and have seen the same thing. The rates of breast cancer incidence are much lower than the general population, or what's been reported in the studies in the general population. And Dr. Rebecca Glazer did a study like that in her population as well, and showed a much less. And she does the same thing. The difference is she doesn't really do estrogen in her patients, so it would be fun to do one with you because we do estrogen. So I think that makes a big difference to look at that data.
Yeah, and I think it's because our patients in general become healthier. They might not be as healthy when they come to us, but you and I mean, we're working on making them healthy. And when you make someone healthy, I tell my patients this all the time, when you let your body heal itself and you become healthy, then things like cancer, I mean, your body's going to have the ability to see that when cells start to mutate, to start fighting that. Like the two women that I had that had this DCIS that got scared into all these things, I told both of them, you are both extremely healthy. I have worked with you for years. Like I told both of them to go actually get a QT scan by Dr. Jen Simmons. I said, I guarantee you if you get a QT scan, there's nothing there and you don't even need to have surgery, because if you had a little cancer, your body probably already fought it. And in both cases, that was the case, because when you're really healthy, your body's going to take care of a lot of that. And so that's why I think our patients have less cancer. When your gut's right, when you're sleeping right, when your immune system's right, like when something changes in your body's resilient. It's made to be like, attack, let's get rid of you. Let's autophagize you, cancer cells. So it's just really interesting. And that's the fun part about medicine and about our body, the human body. Like it's just so resilient. So
It's
yep.
designed
And by the way, we're
perfectly
designed
if
to
you
have a
just
lot
give
of
it what it
estrogen
needs.
perfectly
Yep,
as a
you're
young
right.
woman. Just saying.
That's
Okay.
right. That's right. It's become my favorite hormone
So,
in the last
so I
decade. I'll
appreciate you
tell you
coming
that.
on. I appreciate so much, you talking to me about all this. I have 3 questions that I want to ask you to kind of wrap up. And then when we're done with these questions, you can tell everyone where they can get your book. So everyone loves these questions. Don't overthink it. Super easy. But the first question is, what is one food that is most beneficial and why? You have to pick one. Just because
Why
people
are you going to
remember
make me
this and then
pick
they're like,
one
okay, that's what I
food?
should eat. Like, I have so many people that reach out to me like, oh, this person said this, so I chose this over this. It's fun. Like, just
I'll tell you, my current obsession is einkorn sourdough bread. I mean, I've been researching this einkorn ancient wheat, and I'm not a bread person. I'm not a pasta person. We've got it's messed up our guts. I think our wheat in this modernized wheat is a huge problem with our guts. But man, the more I've researched it and started utilizing it and making it, it has been amazing for me personally. And then even my family, one of my granddaughters suffers really bad from eczema. That's clearing up. Gut issues in my other daughter have cleared up. So there's something to be said. Research einkorn, einkorn. It's my current obsession, and it's pretty fabulous. So, but there's so many. I can't believe einkorn. You stumped me with the one thing, but right now, I mean, it is a super protein. The protein content and the anti-inflammatory, the gluten structure, everything. It's kind of the perfect food, and it's was almost extinct actually, and the woman that revitalized it actually was looking for an answer for her daughter who was suffering terribly from eczema, and also hormonal type of stuff. And she was 13, and anxiety and depression and things like that. So, and discovered it, and it was life changing, flipped it. And I have put patients on just recently, another girl, same thing, rashes. They couldn't figure it out. They cleaned up her diet, got rid of gluten, got rid of dairy, everything, couldn't figure it out. We fixed her gut, and they shifted and started using einkorn, and that kid turned around within 3 weeks. It is amazing. So anyway, einkorn is my short answer.
okay, I'm going to find it. What is one thing that anyone can do that will improve their health that is 100% free?
Sleep.
Yep, I would agree. It's so powerful. And then the last question is, what is one thing you wish you would have known about your health 25 years ago that you would have done differently if you would have known?
I wish
I wish I understood the gut. Um, I really believe, like Hippocrates says, all disease begins in the gut. And I think that's just, if we can just pay attention to that one thing, it will cover a multitude of
I
sins.
completely agree. Me too. I used to eat Taco Bell and McDonald's all the time.
Oh, listen, my favorite was super tacos from Jack in the Box. I mean, the most toxic food probably on the planet. Of course, when I was eating them, it was less chemically laden. I'm surely they were more healthy than now.
Mine was bean burritos with Diet Dr. Pepper. I would have like 3 bean burritos and a like 44-ounce Diet Dr. Pepper. That got me through medical school. So,
And the Diet Dr. Pepper canceled out the bad calories for the bean burritos
yes,
for sure.
100%. Okay, so tell everyone where they can get your book.
Hormone Havoc, you can find it on Amazon, but it's sold online in all the different venues. But Amazon is where you can find it the most easily.
Well, thank
Yeah.
you so much for your time. I enjoyed our
Thank
conversation.
you. It was fun. Appreciate you.
I hope you guys enjoyed this week's podcast as much as I enjoyed recording it. I do this for you guys. I do it to help educate you, and I hope that you found this educational and beneficial. I would love for you to help me spread the word. If you found this educational at all, insightful, or inspiring, please send it to anyone that you think it would be beneficial for. These podcasts take a lot of time to do and produce, but I do them for you. So please help me share it. Please make sure that you are following us on wherever you get your podcast. I would greatly appreciate it if you would leave us a review. That helps me know that you like what we're doing. You want us to keep doing it. Follow me on social media. Please feel free to reach out to me and let me know who you want me to interview you, what questions you have, because I love helping educate you and answer all those questions. Also, please keep in mind, Modern Endocrine now has a license in 39 states. So we are working on 50, but we are at 39. If you would like to be a patient and discuss any sort of issues that you have that we could help address, we would be honored to do that. If you are in Oklahoma, you can come to our clinic, but if you're outside of Oklahoma, we'll do it virtually. We can even do virtual visits in Oklahoma as well, so it can all be done through telehealth, and we are happy to help you discuss any range of things we do, whether it be just gut health, just hormone health, weight loss. If you want a whole transformation, if you want to do preventative medicine, longevity, we would be more than thrilled to help make you a happier and healthier version of yourself. Make sure that you join us next week for the next episode. Have a great week. The information presented, including any materials discussed, referenced, or linked within this podcast, are for general educational purposes only, not the practice of medicine. No doctor-patient relationship is formed from you listening to this podcast or utilizing any of the information provided. I am a doctor, but I am not talking to you as your doctor. The information provided is not intended to diagnose or treat health problems, or take the place of the professional medical care provided by your doctor. If you are experiencing any health problems, including problems you believe have been touched upon in any respect within this podcast, you should consult your doctor about the problems without delay. You may ask your doctor whether he or she believes the information I have provided would be helpful to you, but you should still consult your doctor immediately and follow his or her medical advice as your treating physician. I'm just here to provide you basic knowledge about the issues we discuss so you are more aware of them and can better discuss them with your doctor. That's why we call it Back to the Basics. Join me on the next episode as we continue our journey.